Good afternoon, everyone. Welcome to today's hands-on from the Department of Cardiology. And today's topic is, cardiac masses, the multidisciplinary approach. So, the focus will be on the cardiac tumor, although these can be sometimes non-neoplastic also. And they are, little rare, but AIIMS being a referral center, we are seeing them on a regular basis. So, we thought we'll share our experience with everybody. And we will aim to provide a comprehensive overview from clinical, from imaging and pathology to surgical, medical and radiation, medical therapy, radiation therapy for these patients. So therefore, highlighting the collaborative approach that is required for management of these, often very difficult cases. So we start first with the masters in children, then masters in on the rare cardiology side, and then to other specialties like the imaging and pathology and the surgical and the radiation pathology. So first, Praveen will be showing on the cardiac muscle in children.
Good evening, everyone. Welcome to the anesthesia. So I will be giving a overview of the pediatric cardiac tumors. So they are rare, but they can have a disproportionate impact on the children, especially even if they are benign, they can have a disproportionate impact. So if you see, all the tumor appear as masses, but all the masses are not tumors. So it is very important to differentiate everything. So it could be a thrombus, it could be a vegetation, or it could be any other structural lesions also. So why it is important? Because differentiating it has implications on the treatment and also the prognosis. So we will be today focus on the tumors, especially pediatric cardiac tumors. So this tumor has fascinated physicians and surgeons for over the centuries. From the first description for Riata in 1559 to the first laboratory incision in 1952. After this, more than 300 case reports and more than 50 case series have been published, and even two systematic review and meta-analysis has been published. So if you see the epidemiology, per se it is a rare thing. So if you see the numbers through the various series, it is around like 100 to 150 per lakh. And out of this, the rhabdomyoma constitutes nearly 90% of the tumors, and they are benign, and it will depend upon the age group also. And rhabdomyoma, along with the pericardial teratoma, constitutes nearly around 70% of all the pediatric cardiac tumors. So this was the Boston Children's Hospital study, where it was a retrospective data analysis of the echocardiography, which included fetus to the adolescents. If you see here, the rhabdomyoma constituted nearly 64% of all the tumors, followed by myxoma, which was 15%, followed by fibroma, and then teratoma. And in this slide, we can see that there are secondaries which constitute nearly 4%, and others which include other benign tumors and also the primary malignant tumors, which was around 7%. And what about this 7%? So if you see the malignant primary cardiac tumors, which is further rare than the benign cardiac tumors, in a database of over 30 years, which include approximately 20% of the US population, only 25 children less than 20 years had a primary malignant tumors. If you see the annual incidence, it was nearly less than 0.07 per million. For example, if you take India with a population of 140 billion, it will constitute nearly 100 cases per year. So out of this, the sarcoma were the first prominent one, followed by malignant germ cell tumors, and followed by lymphomas. So they are, even though they are there, they can have a very great clinical significance. Some may remain asymptomatic. If they involve it can involve the outflow tract obstruction. It can cause the inflow tract obstruction. By involving the myocardium, it can cause the arrhythmias. It could be a bradyarrhythmia and even a tachyarrhythmia. And with this, the patient may have a significant heart rate. So not only it has an impact on the cardiac chambers, but also it can have systemic manifestations also. So it could be a constitutional symptoms like fever, malaise, weight loss, or it could be an embolic manifestations like pulmonary pulmonary thrombic systemic embolism like thrombotic per se, or the so and some other manifestations may be because of the secondary. So this was one study where 28 studies was combined from 10 countries involving around 750 patients. The mean age of diagnosis was around 3 years, and the asymptomatic was constituted only 7.2%. If you see the other clinical presentation, they presented with dyspnea, some patients with chest pain, and these patients, nearly 15 to 20% of the patients were diagnosed prenatally. So how to approach these tumors? Once you have these tumors, everything will has a constellation. So we have to consider everything: the age, localization of the tumor, clinical context, and the characteristics of the tumor. So if you see the age-based distribution of the tumors, like I said before, rhabdomyoma constitutes predominant tumors in pediatrics. But if you see once the child ages, the rhabdomyoma has spontaneous resolution. So the fibroma picks up and comes nearly 23%, where rhabdomyoma falls to 45%. So then coming to the location and the number of the masses, like the certain tumors have a predominance for the certain chambers. So if it is an atrium, most likely it is a myxoma or it could be a thrombus or lipoma. If it is a ventricle, most commonly pediatric tumor, it's a rhabdomyoma followed by fibroma. And in the wall, it could be a thrombus, vegetation or fibroadenoma, but it is rather in children, it's a common old ages. And even the tumors can involve the pericardium, which can include teratoma and lipoma. So coming to the number of masses, mostly if you find that more than one mass, most likely it is a rhabdomyoma. So we can see the multiple masses in the first video. Here there is one mass, there is another mass here also. And if you see the second video, this is the case of a fibroma. You can see a solitary mass. This is the encapsulated mass with a granular appearance. And this is the example for the myxoma which is present in the atrium. And the next one is the fetal echo, which was showing a teratoma. So, other than this age, number of tumors, and we have to consider the patient has a mental dysfunction also. And like I said before, whether the fever or constitutional symptoms is there or not. And other one important thing is that rhabdomyoma is present along with the tuberculosis. Nearly 90% of rhabdomyoma has tuberculosis, and 50% of tuberculosis has rhabdomyoma. It is once you have a multiple rhabdomyomas, more likely the patient has tuberculosis. The other one is the introverted teratoma, which has a critically unique presentation because of the large pericardial effusion, and it can be even in the fetus. The other tumors are hemangioma, sarcoma, and lymphoma. And through the investigations, X-ray is found in 80% of the cases, and some tumors may need a blood investigations like alpha-fetoprotein or beta-HCG. The main role comes with the echocardiography because it is easily available and it is mostly sufficient in all the cases, and it may aid in tumor differentiation also under follow. The other modality is cardiac CT and cardiac MRI. CT may aid in extent of the tumor and calcification. So just I want to finish it with outcomes. Even though they are can significant impact, the outcomes are not bad. So it was a surgical series where nearly complete precision was possible in 70%, and the area 28% was nearly 93% for the benign tumors. So with this short overview, I would like to call Dr. Swaminathan to give our experience for the past few years on pediatric cardiology.
Good afternoon, everyone. As my colleague previously gave an overview of pediatric cardiac tumors, so I will be sharing our experience in dealing with pediatric cardiac tumors. So first, I will explain about cardiac rhabdomyoma, which is the most common benign primary cardiac tumor in children. So in the last 5 years, we diagnosed a total of 34 children with cardiac rhabdomyoma, and out of them, 11 patients are symptomatic and 23 are asymptomatic. And among these 34 children, 7 were antenatally detected. And most of these children fall between 1 month to 6 months of age, with the oldest case is age of 6 years. And among the asymptomatic patients, majority of them were referred by pediatric neurologists as a case of suspected tuberculosis or a confirmed tuberculosis, whom we screened and diagnosed cardiac. So the diagnostic imaging of choice is most of the time for cardiac rhabdomyoma is a 2D echocardiogram. These cardiac rhabdomyomas are multiple isoechoic intracardiac masses, and presence of a non-cardiac TAC manifestation along with this echo finding always fits the diagnosis of cardiac rhabdomyoma. If we see the distribution of mass, most of the time it involves the ventricle, commonly left ventricle followed by right ventricle, rarely involves the atrium. And in doubtful cases where this is a solitary mass or involves an unusual location like a pericardial extension, we can go for other imaging modalities like cardiac MRI for wider tissue characterization. So in this 2D echo, we can see a huge intracardial isoechoic mass coming in the IVS. This patient also had features of non-cardiac tuberculosis features. So this is a case of cardiac glaucoma. And in this patient, we can see a mass in the left ventricular outflow tract causing an outflow tract obstruction. And this is a color Doppler image where we can see significant turbulence and non-laminar. These cardiac rhabdomyomas usually grow with an intra-atrial life maximum of the second trimester till 32 weeks. That's the time where they are commonly diagnosed. So this is a fetal echo image of a cardiac rhabdomyoma, where we can see multiple isoechoic intracardiac masses involving the right ventricle, left ventricle. So among the 34 children whom we diagnosed, majority of them are asymptomatic, like I mentioned, but among the other symptomatic children, 4 patients had outflow tract obstruction, 4 had arrhythmia, 4 presented with heart failure secondary to a large mass more than 20 millimeters. So this cardiac rhabdomyoma is also known to affect the conduction system of heart. So this results in arrhythmia in 16% of these patients. This rhabdomyoma itself can act as a substrate or act as an accessory pathway, resulting in pre-excitation, which is the common mechanism of arrhythmia in this patient. So this pre-excitation results in supraventricular tachycardia, which is the most common arrhythmia in rhabdomyoma, followed by ventricular tachycardia and ectopic atrial tachycardia. Lastly, they can also be causing bradyarrhythmias like heart block. In our patient, 2 patients are STT with pre-excitation, 1 had ventricular tachycardia, 1 patient had complete heart block. So this is the ECG of the patient with rhabdomyoma who initially presented with SPT, but after we avoided the SPT, we can see there is a short PR interval and a slight upstroke of QRS. This is delta which suggests pre-excitation. And in another patient who presented with tachycardic emergency, we can see white QRS complex tachycardia. This is ventricular tachycardia. 2D echo in this study show multiple cardiac rhabdomyoma and LV. Despite though the ventricular tachycardia supported the samedron and even the DC cardiac, there was recurrent episodes of ventricular tachycardia secondary to rhabdomyoma in this patient. So now coming to the management. So we have to check the cardiac rhabdomyoma. So they are grouped into 2. Either asymptomatic or symptomatic. In asymptomatic patient, normally we follow conservative management because spontaneous regression up to 50 to 70% by 2 years of age is documented. Suppose the patient is symptomatic in the form of heart failure, arrhythmia, or outflow tract obstruction, we can do by 2 parts. One, previously they were sent for surgery or surgical resection of mass. But nowadays, a newer pharmacological agent has been developed for the same for treating cardiac rhabdomyoma, which is mTOR inhibitors. Why mTOR inhibitors in cardiac rhabdomyoma? These cardiac rhabdomyoma have overexpression of mTOR pathway, which results in cellular proliferation and cellular differentiation. So these mTOR inhibitors like sirolimus and everolimus blocks this pathway and helps in regression of cardiac rhabdomyoma, which has proved effective in other non-cardiac TSA tumors like renal angiomyolipoma. So based on this, in the last 5-6 years, many case series and case reports are documented which show significant efficacy of this mTOR inhibitors in cardiac rhabdomyoma, showing up to 86%, 70% regression. And no major adverse events were related to sirolimus occurred in any of these case series. So now sirolimus is considered a safe, effective first-line option for symptomatic cardiac rhabdomyoma. So in last 5 years, among the 11 we treated total 11 symptomatic cardiac rhabdomyoma with sirolimus in our department. In this column, we can see almost all of the patients had complete resolution of obstruction, arrhythmia, or heart failure with significant tumor size reduction more than 50% in almost all the cases. Only 2 of them had a minor side effect of hypertriglyceridemia, secondary to sirolimus, which was managed conservatively. So none of our patients required any surgical resection in the last 5 years after we started using mTOR inhibitors. No significant adverse effects. So this is the echo of the first patient which I showed. This is for diagnosis. This is 1 month after sirolimus therapy. We can see the significant reduction of size rhabdomyoma, and at 4 months there is complete disappearance. So now we discussed about rhabdomyoma. Let me just explain about some other 2 to 3 important interesting cases which we have. This is a 4-year-old girl who presented with recurrent symptoms of heart failure. So on echo, we found a large isomorphic well-circulated mass near the pulmonary valve, resulting in significant ventricular outflow tract obstruction. That was leading to the heart failure in this patient. So this patient underwent cardiac MRI. Initially thought it to be a benign etiology. Since the tumor was related very near to pulmonary valve, to preserve the valve integrity, we went into incomplete tumor resection. Then, unfortunately, histopathology came positive for a grade 2 leiomyosarcoma. Then, we left a small tissue type around 2 mm. That 2 mm grew to around 15 mm in the next 4 months and then resulted again in outflow tract obstruction and heart failure. So then, after consulting Medoc team, we decided to go for a considering like primary chemotherapy rather than a second surgery because of the complications associated with surgery. We started the patient on doxorubicin and hypoxia. But despite 2 cycles of chemotherapy, the child continued to grow. Then we went to an oral multi-targeted tyrosine kinase inhibitor like pazopanib, with which there was complete tumor resolution at 6 months. Currently, the child is doing fine. So this is the echo. After the surgery, we can see the regrowth of tumor, resulting in turbulence and significant RV Then at 6 months post pazopanib, we can see the tumor has completely disappeared with non-linear. This is another case. A 9-year-old boy with hemoptysis. He presented with a huge mass in the right atrium, which is protruding into the tricuspid valve, which is hyperechoic well. Later, like in MRI, it turned out to be myxoma. Though cardiac myxoma is pretty common in adults, it's pretty rare in children. The commonest site is LA followed by RA, rarely involves the ventricle. In our experience in the last 15 years, we diagnosed total 13 pediatric cases of cardiac glaucoma, and their distribution also mirrors the typical distribution, and the mean age was around 8 months. All of this patients underwent surgical resection, and there was no recurrence in any of these patients. I'm skipping this because of the time. So, cardiac tumors are rare in children. Rhabdomyoma is the most common tumor, pediatric tumor, often associated with tuberous sclerosis. Sirolimus is safe and effective therapy for symptomatic and large cardiac rhabdomyoma. Other tumors are rare in pediatric age group, have varied presentations, and need a multidisciplinary approach for diagnosis and management.
Good afternoon, everyone. So, Dr. Praveen has elegantly highlighted about pediatric cardiac tumors. So, some of it will be an overlap, but I'll try to highlight the things that are relevant and pertinent to adult tumors. Now, number one thing, the most common cardiac tumor in an adult is metastasis to the heart. And these metastatic tumors are over 100 times more common than primary cardiac tumors. Primary cardiac tumors per se are rare, about 1 per 100,000 patients per year, and 80% of these primary cardiac tumors are benign. So, based on the data of about 22 large autopsy series, the frequency of primary cardiac tumors was about 0.02% of these autopsy series, which is about 200 tumors in 1 million autopsies. Obviously, if we look at the imaging data in the era of multimodality imaging, we detect more incidental and small masses. So imaging-based prevalence estimates are higher than autopsy series. The most common tumor, primary cardiac tumor in the heart in adults is myxoma, which constitutes about 40 to 90% in different series out of all the primary cardiac tumors. The next most common is papillary fibroblastoma. The other ones like hemangioma, fibroma, lipoma, rhabdomyoma, which may be more common in children but are rare in adults, less than 5% of the total primary cardiac tumors. In the malignant ones, overall just 10 to 20% of primary cardiac tumors in adults are malignant. And out of the malignant ones, angiosarcoma and rhabdomyosarcoma are common. Other sarcomas, which include leiomyosarcoma, pleomorphic sarcoma, undifferentiated sarcoma, synovial sarcoma, they're rare. We'll be showing you some of the cases in a while. Chamber predilection, it varies by the exact tumor histology. For example, myxoma is most common in left atrium, specifically in the interatrial septum. On the other hand, papillary fibroblastoma It's a tumor of the cardiac valves. Angiosarcoma, the most common site is right atrium. Myxomas predominantly occur in adults between 3rd and 6th decades and is about twice more common in females than males. Rhabdomyomas, as highlighted, are more common in pediatric populations, specifically infants, and are associated with tuberous sclerosis. Sarcomas usually affect young to middle-aged adults, whereas papillary fibroblastomas are more common in elderly. Symptoms may mimic other cardiac diagnoses and occur either because of obstruction caused by these cardiac masses, in which case they might mimic classic valvular stenosis. For example, a left atrial myxoma will mimic mitral stenosis. Embolic events, which may be systemic or pulmonary emboli. Arrhythmias, tachyarrhythmias as well as bradyarrhythmias and conduction blocks. And many of these tumors, especially myxoma, by producing cytokines can produce constitutional symptoms. Now I'll be discussing briefly about each one of these. The more common one of these, recommended in animal echocardiography even after surgical resection. Papillary fibroblastoma is the next most common benign primary cardiac tumor in adults and is primarily a tumor of cardiac valves. More common in aortic and mitral valve position, as is seen in this picture, a small frond-like pedunculated mass on the aortic valve leaflets. It's important clinically because it may cause embolic events and therefore leading to stroke or coronary embolism. And sometimes it's picked incidentally on imaging. And because of their small size, transesophageal echocardiography is superior to transthoracic echocardiography. The management, surgical excision is recommended if the tumor is more than 1 centimeter, left-sided, or if it's symptomatic. Otherwise, small tumors incidentally detected may be managed conservatively. The most common malignant tumor of the heart, primary malignant tumor of the heart, is angiosarcoma in adults. It's more common in right atrium, as is seen in this picture, a large mass with polylobate appearance and infiltrating across the cardiac borders. Clinical presentations include right heart failure, and because they involve the pericardium, can produce pericardial effusion and pericardial tamponade, and can present with manifestations like arrhythmias. These are highly aggressive tumors, and on imaging manifest as large infiltrative polylobulated masses which infiltrate into the adjacent structures, adjacent pericardium, valves, and other chambers. These patients have metastasis at diagnosis in about half of the cases. The most common site of metastasis include lungs, bone, and brain. While definitive therapy is not established, the experience is based on case series only from different hospitals around the world, but overall the prognosis remains poor. Mean survival is less than 6 months. Now I request Dr. Alaina to discuss about the echocardiographic evaluation of these cardiac tumors.
Very good evening to all. Today I'll be discussing the role of echocardiography in evaluation of cardiac disease. So echocardiography is the first imaging modality because it's readily available, it's cost effective, there is no radiation exposure, and it's portable. It helps us to assess the size, location, mobility, extent, and the pericardial involvement of the tumor, and it also helps to assess the hemodynamic significance of the tumor, like they might cause some regurgitation or stenosis of the valves. However, echocardiography has its own limitations, like we cannot catheterize the tissue, and sometimes we might have poor acoustic window, as in obese patients or those with chronic lung disease. So, there are some subtle markers which help us to differentiate between a thrombus, a tumor, or vegetation. So, a thrombus usually has a layered appearance, and usually they have associated findings, like the patients may have mitral stenosis, or they might be in atrial fibrillation, or they might have an akinetic or dyskinetic segment in the LV. And usually the thrombus is found in LA appendage or LV apex, or sometimes in patients with the renal cell carcinoma, we can find a thrombus transiting via IVC to RE to RE. Vegetations are usually found on the valves or on the CID leads. They are found on the low flow side of the valves. They are irregular and mobile. Different cardiac tumors have different directions for cardiac chambers, and they vary in appearance. So I'll be discussing in short about the echocardiographic findings in different cardiac tumors, since it is already been discussed by Dr. Musin. So this is a cardiac myxoma. It's an intracardiac mass, and most commonly it's found in the left atrium. It's pedunculated and attached to porta vallis. And it's during diastole, it goes in the LV, and during systole, it retracts back into the LA, giving a retting ball-like appearance. And it has heterogeneous echogenicity. As we can see, there are some echolucent areas in this mass, which signify that some cystic or necrotic changes might have taken place. And the classification is found in nearly 14% of myxomas. So here we see the myxoma has caused mitral regurgitation. And this is a typical N-mode echocardiography of a myxoma, where we see this is the interventricular septum. This is the RV, this is the LV. In the LV, we have the anterior mitral leaflet and the posterior mitral leaflet. During diastole, when the mitral leaflets are opening, that is, they are separating, the myxoma is prolapsing into the LV through the mitral valve, causing mitral stenosis. Lipoma is broad-based, immobile, well-circumscribed, homogeneous mass, and it appears hyperechoic in the cat. Paternary fibroblastomas, as it has been already described, it is attached to the endocardial surface of the valves. Aortic and mitral valve is the most common. They usually don't cause valvular dysfunction, and the most typical presentation is embolic complications. They are very small in size, and they are attached to the valves by a small stop. And sometimes they can give an appearance of seeing anemone on high resolution echocardiography. And they have shimmering borders because it's postulated that there may be vibrations at the tumor and blood interface because of the finger-like projections which are present on the surface of these tumors. And since they are very small in size, TE is more sensitive. Angiosarcomas have already been described in detail, and they are usually broad-based mass in right atrium, and they are heterogeneous, and these can have pericardial effusion, and they might also present with direct pericardial extension. And this is a case of vegetation. This patient had a CID lead in situ, and then a vegetation is attached to the CID lead, which is freely mobile and hyperechoic. So now I would like to call Dr. Neville to share with us our 1 year experience.
Good afternoon, everyone. So, I will share last 1 year experience we had on cardiac masses. So, we had total 20 patients. The mean age was 37.8 years, ranging from 5 to 69 years, and male to female ratio was 1:1. And all patients had dyspnea, mostly mild symptoms like inherited classic symptoms. Other symptoms were heart failure, pedal edema, chest pain, C4, systemic embolism, ventricular tachycardia, and intermittent complete heart block, signifying a diverse nature of presentation of this cardiac masses may have. So, if you see the location-wise distribution, most of these masses were present in left atrium, right atrium. Some of them involve both the atrium and ventricles, and some of them also involve the pericardium. And 50% of the masses were mobile. This is important because it increases the risk of systemic embolization as well as symptoms. And mean size was 6.82 centimeter, ranging from 2 to 15 centimeter. Regarding histopathological diagnosis, most of these masses were malignant and followed by benign. We had one tubercular vegetation also. And if you see etiology-wise distribution, myxoma top of the list, followed by various malignant tumors like angiosarcoma, leiomyosarcoma. We had follow-up of 15 patients among these 20 patients, and among them 8 patients are alive, and 6 patients died, and 1 patient of angiosarcoma still is under us doing treatment for angiosarcoma. So let's see some interesting cases from our department. Some of these have been published in reputed journal. The first case was a 19-year-old male who presented with exertional shortness of breath, palpitations, and breathing for 4 months, along with low-grade fever. On examination, he had clubbing and late-pitching ejection systolic murmur and an early diastolic murmur in the aortic region, along with pan-systolic murmur in the mitral area. blood culture was sterile, and he had raised PSA. So we did echocardiography. As you can see, there is there is a mass at the LVOT region. This is paraspinal short long axis view. This is LA, left atrium, left ventricle. This is aorta. And as you can see in this view, there is significant this mass causing significant stenosis as well as rapid regurgitation and moderate mitral regurgitation. So we suspected vegetation or LVOT myxoma. We did MRI also, which suggested thrombotic mass. So according to the clinical feature, we gave a diagnosis of infective endocarditis with vegetation, and we gave antibiotic therapy. On day 70, the patient's condition deteriorated. He underwent surgery with the excision of the mass with aortic valve replacement and mitral valve repair. Right now, post surgery, the patient is doing well. This is another example of vegetation presenting as cardiac mass. It was published in 2006 in a journal. This was an 8-year-old male who underwent aortic valve replacement for severe aortic regurgitation. And after 4 weeks, he developed infective endocarditis because of fungal infection. He was treated for that, and the prosthetic valve was replaced with a homograft of aortic valve. 3 months later, he again presented with subacute limb ischemia. So on echocardiography, this is still images. As you can see, this is again the plaques view, and this is left atrium, left ventricle, and aorta. There is a fungal ball presenting as cardiac mass. Here also you can see. So the patient was again planned for surgery, but the patient died because of systemic embolization. So I have few more cases, but because time is less, so I would invite Dr. Vinita over from the department. Okay, I will invite Dr. Sandeep Shetty discussion over the biopsy.
So as you've seen from the images from Mosin and Elena, usually you're able to get an idea of the diagnosis from the echocardiography or where the tumor is located. And if you're not sure, then we can take the help of radiology or CT PET imaging. But sometimes you are still not sure. So you need to get to the tissue. And if you are not able to get to the tissue from outside the heart, then you have to go inside the heart and get to the tissue by doing a biopsy from inside the heart. So you ultimately have to take a biopsy from inside the heart and then do a frozen section, because often, since you're doing practically a blind procedure, you're doing from inside the heart, you have only the fluoro and the echo to guide you to take a biopsy, keep the patient outside, wait for the pathologist to give you a report, and I think if he says there's nothing, you go again and again and again till you get an answer. So this is the hardware that we use. This is the bioptron. This is a close-up view of this. This is what we use to get a piece from the heart. And this is just a model of showing how the biopsy is done. You have a guide wire which is guided near the tissue. A sheet is put, and then the bioptron being guided inside the tissue. This is how it works. You inject some contrast, guide the sheet, and put a bioptron in that area. This is one example of a patient who had an RA mass. The echo showing the mass. Bioptron is guided from the neck. Depending on where the mass, you can use either a neck approach from the jugular or an approach from the IVC into the artery. This patient, for instance, had a RA lymphoma. This is another patient who had RA mass. Young patient who had come with fever. So this is the RA mass. You saw this RA mass from Lina's images. So we went from below, imaged the mass, injected some contrast. We did simultaneous fluoroscopy and also by echocardiography. This is the bioptron coming in. We go in, approach it, guided by echo also, and take a biopsy piece. And this turns out to be an angiosarcoma, which is one of the commonest sarcomas that we see when we do a biopsy. So chemotherapy started. Post-chemotherapy, the tumor started to regress. Ultimately, of course, the long-term prognosis for most of these sarcomas is not good. LV mass, a fibroma, which was clearly a fibroma based on the imaging we got from MRI, did a biopsy, jammed it back deep inside the fibroma, biopsy result, normal tissue. So fibroma are deep inside the myocardium. So what we got was normal tissue which is over the tumor. So these are some of the ways by which you can actually go inside the tumor. This is not a very easy procedure. Sometimes you can. We have had one mortality out of all these patients that we've done, not more than one mortality, but this is a procedure which can be done.
Good evening, everyone. Here to give some glimpses into the role of cross-sectional imaging in the assessment of cardiac muscles. So, the goal of imaging is really to detect the lesion, to localize it, to examine the extent of the lesion, the infiltration, to some extent, characterization, which you will see the MRI is gold standard for. Also, to do researchable planning, CT really helps us in doing that with its three-dimensional reconstruction capabilities, and also following up of these patients. Sometimes they are on therapy or watchful waiting, and we have to assess the sizes, which we have to do reliably. So, the role of CT really becomes very important in some of these tumors. It really helps in assessment of extent the localization, like this is the case of left atrial myxoma, and you can see the typical location over here, and you can do the accurate sizing over here. Also, the CT is very good for a few things, like you can detect fat, you can detect calcification. You are very confident with your diagnosis of CT for this. So presence of calcification, like in this patient, there is this calcification in this valvular mass in the tricuspid valve. And presence of calcification really takes us more towards the benign etiology. Although it's not like malignant lesions won't be having calcification, but it might take us towards a particular diagnosis more. Also, for the assessment of lipomas, fat, CT is really characteristic. We see a particular muscle unit and we know it's fat, and it can't be anything else. Further, CT, the most important role of CT probably is where it's used to assess the relationship of these muscles to coronary arteries. So usually we do an ECG gated CT for this purpose. Like this was the case of the right atrial angiosarcoma, and you can see how this mass is abutting the right coronary artery, although it has not infiltrated into the other side of the right coronary artery. But this information is really helpful if the patient goes for surgery. Also, sometimes we see coronary artery disease in patients with cardiac masses, which can be dealt with in the same setting during surgery if need be. So, this is also an important role of CT. For cases affecting the vascular tissue specifically, and this was the case of pulmonary artery angiosarcoma, and you can see infiltrated mass lesion within the right pulmonary artery. There is some component intraluminally over here. Especially for these cases also, CT really proves to be really useful. Also, we can examine adjacent lung parenchyma for any metastatic lesions, etc. So, these are some really important uses of CT, but having said that, it has its own limitation. It comes with a penalty of radiation, and also it is limited in tissue characterization. Like Alina said, for echocardiography, the same limitation applies to CT as well. And this is the reason why MRI is the gold standard for tissue characterization when it comes to the cardiac muscles. So a thrombus would be typically avascular, there won't be any contrast enhancement. You'll see it completely dark. And also MRI helps us in differentiation of true tumors from pseudomasses. See some example. So the upper panel here, this is a mass lesion, typical lesion of a myxoma, interradial septum, and you can see on the post-contrast images, it is enhancing completely. There is no non-enhancing component over here per se. But if you see the lower panel here, this is the mass lesion, same location, myxoma again. But here you can see there is an enhancing component here, and then there is this dark area overlying it. So this is a myxoma with overlying thrombus. So this is the utility of MRI really. In addition to, of course, accurate sizing of the lesions. Further, we have a sequence which is called perfusion sequence, which will give you an idea of how vascular the tumor is. So this is the case of right ventricular myxoma, and you can see it takes the contrast even in the first pass. So you can have some idea, and this information really helps the surgeon when doing surgery. So this case here was referred for query tumors, and we found this was actually a hypertrophic crista terminalis. So because of the enhancement characteristics, you would know this is a normal tissue rather than a thrombus. So this is where MRI is really useful. One of the most important uses of MRI is to distinguish between benign versus malignant, and I think this was kind of discussed also earlier. But this is an example of right atrial angiosarcoma, typically infiltrative borders, interatrial septum, left atrium here, there is adjacent pericardial effusion over here. But if you see the post-contrast characteristics, very dirty looking heterogeneous kind of enhancement. And you can see this non-enhancing pericardial effusion here. But if you compare it with a benign tumor, like a fibroma over here, you can see how well capsulated, well marginated the lesion is. And on the post-contrast sequence here, it's a homogeneously enhancing lesion, so big, but it is so homogeneously enhancing. So we can have some idea based on these characteristics whether the mass is benign or malignant. Having said that, it's not 100% foolproof many times. And finally, we can do functional assessment of MRI as well, like in echocardiography. So you can assess how it's compressing the valve, the right ventricle. You can do volumetric assessment. And as we know, for ejection fraction assessment or volumetric assessment, MRI is the gold standard, specifically for the right ventricle. So that makes MRI kind of a workhorse for us. A little bit about the very new sequences that we have, parametric mapping. Nowadays, they are kind of part of our protocol in all the patients. You can have some idea about the content of the tissue based on the mapping characteristics. So this is the case of a tumor involving the pericardium inferiorly over here. You can see diffusely enhancing lesion. On T1 mapping, the value was very high. It was 1650 milliseconds. Our upper limit of normal is maximum 1050 milliseconds. So this immediately raises an alarm as to this could be a fibrotic tissue because of very high T1. And we gave it like a fibrotic mass, and on biopsy it was revealed to be a myofibroblastic tumor. Another example, T2 mapping. So similarly, like T1 mapping is used for fibrosis, T2 mapping is used for water content, edema. So this was the case of intrathecal cardiac MRI. We saw a mass lesion over here. So usually we have a doubt whether it's the rhabdomyoma or fibroma. So rhabdomyoma would be hyper-intense on T2. It has water. So on T2 we found high water content. It was 70 milliseconds, and we were kind of reasonably sure it was a fibroma. Further, this case was published after the study the patient did well. So these mapping features can also really help us in assessment of diagnosis. So to summarize, imaging workflow after echocardiography, there is one imaging modality that we do. It is cardiac MRI. But depending upon if we need to assess calcification, coronaries, PAC, we do CT on case-to-case basis. Because of the radiation, we keep that in mind and try to be judicious in the use of CT. Thank you. Would you like to call upon next? Dr. Duncan. Now I would like to call Dr. Duncan from Media Medicine Department.
Good afternoon, everyone. I will be talking about the role of PET in masses. For the evaluation of cardiac masses with FPG, we need to prepare patients such as so as to suppress the myocardial physiological FPG uptake. We do it by giving the patient high fat and low carbohydrate. Other than FPG, there are also equally important in certain cases, such as liver and genes. As we all know, metastatic lesions to the heart are much more common than primary cardiac lesions. But one thing is sure, malignant cardiac masses are very aggressive and they tend to show very, very high FPG uptake. The role of PET includes the differentiation of malignant lesions from benign lesions, and it has a role in staging to evaluate disease action and detect distant metastasis. And it can also guide biopsy sites because not all lesions are especially in the case of cardiac lesions. And last but not least is the treatment response and the mechanism of detection. So in the last 5 years, 28 patients underwent approximately 28% in the winter HCT. Majority of them were severe lesions or traumas, and the 7 of them were methods. This is a case of cardiac lesion in the left ventricle, which is with no FTC. This is an interesting case in 57-year-old male. We see the right side is the FTC bed and left side is the FTC bed and the right side is the you see a well-defined and nominated lesions showing just uptake on both the HCTs and the first located in the atrial ventricular group, in the right atrial ventricular group. It was a case of myeloma. And this is a case of neonatal post-excision. And in the baseline scan, after the excision, patient had a residual disease in the right ventricle with multiple metastases. This persisted even after giving the follow-up. And this is a case of poorly differentiated cerebral sarcoma of the pericardium. You see there's an irregular infiltrated pericardial mass with multiple lymph node metastasis in the intestine. And last, this is an angiosarcoma in which year-old patient. The primary was in the right atrium with pericardial invasion and multiple metastases were there in form of metastasis in the intestine as well as multiple bone metastasis. After chemotherapy follow-up, you see there is regression or reduction in the size and the uptake of the localized disease size in the right atrium, there is reduction in the size as well as in the lymph nodes. However, there were multiple skeletal lesions. Multiple skeletal lesions appeared as new findings. So, despite local response, there can be systemic protection. So, this I would say.
I would like to call Dr. Rajshekar from the department.
Good evening, everyone. Thank you for this opportunity. So, I'd like to briefly discuss the surgical management of cardiac diseases. So, the one thing that we have to keep on the back of our mind is that the way that the surgeon approaches a tumor is very different in cardiac surgery as compared to hospital. Because they always deal with a positive tissue tumor. You can't just take out everything and come back. You're always burdened with the problem of reconstruction. Like my colleague has discussed previously, you need a stomach, you need a pericardial, you can carry it there. But then you might have to sacrifice the pulmonary valve. And sometimes you always think, given the age, the structure of the valve, the feasibility of reconstruction is always the burden. So, this is the back of the mind, we just discussed the slides. So, this has been discussed in detail previously. But I would like to reemphasize that most of them are secondary, in adult spectrum at least, and then in the secondary, in the primary tumors, most of them are there. But then sometimes the pathology of these lesions do not correlate exactly with the same. So, even a benign lesion might be significant symptomatic to the patient and might have come. And we can't forget about the influence of this IBS and radiatus. And the last CCL also was on leukemia, which was extended to the right. So, surgical indications, yes. Symptomatic lesions, absolutely. Obstructive lesions, any lesion which is at risk of causing an embolus will be treated on an emergency basis. We do not risk any lesions that are causing hemodynamic compromise, or if asymptomatic but with the growing very rapidly, or if there is a still window to resect if a suspicion of malignancy is there, take over the biopsy is generally avoided, but if you feel that it's a malignancy that can have a chemotherapy which can be given adjuvantly or years manner, which will improve the operative outcome. So approaches, just to streamline the thought process, we can go with the zonal approach, tumors involved in great arteries, generally mediastinal tumors like thymoma, which often get concerns for because they're affecting all this loss of generally they can be resected safely unless if the data is removed, we and venous diseases, we often deal with venous carcinomas, which extend into the IVC and then into the but then they can have a loss of factor at any of these levels, which might require a reconstruction. Here we see an IVC reconstruction for sarcoma. You see the diaphragm here, and then just take the diaphragm that is reconstructed with the diaphragm.
below that it was restricted by atrial tumors, we deal with it more in detail. So ventricular tumors, again, positive is a concern in these lesions. We don't have much tissue to work when we are resecting this. And reconstructive options are limited. Cardiac valve, capillary fibrillary like discussed. It is often affecting the lungs. And when we take it out, sometimes we have to go ahead with it. Technique, the key thing to keep in mind for surgeon is that you are working on a dynamic organ. And then if you're dealing with a renal lesion or a malignant lesion, things can go haywire. So it is important to isolate with minimal handling, put the patient in cardiopulmonary bypass, exclude the inflow, exclude the outflow. When the heart is still and empty, sometimes you go on DSCA if you feel that the respectability is a concern or the flow is a concern. And once the heart is free of blood, then you go ahead and take it. So atrial is the one that we often do. So blockation of the region along with the HC and we reconstruct it. So this is our technique for the myxoma, how we access the myxoma. So we isolate the inflant active to the region of abdomen. Our specific policy is that once we take out the myxoma, we generally tend to cauterize using a diathermy in the base of the myxoma. Although there is no artificial to prove this evidence, we feel that that helps with the recurrence path. So this is what we do. This problem. So the heart is isolated, there is no flow in and out. Here humor is the left atrium. Using minimal handling, on good days it just comes out, but then there is fixedness. So we take out the humor to make sure that we use coordinate the base of the we can just use this. Yeah, so that's the next one. Malignant tumors, radiological expression, and there is a radical approach of organ transplantation where you just take the heart entirely out of the back table, reset whatever you want to reset, reconstruct whatever you want to reconstruct, and then put the heart back. So slightly aggressive approach, but then in some centers it is done. And systematic therapy is always important. So next level. Reconstructive options predominantly pericardium, vortex, and PTFE patches, but sometimes you might have to do or a prophetic. Post-operative management, intraoperative is very helpful in the surgery just to ensure the complete resection. Prognosis, the range of it excellent, recurrence is close to 1 to 5. Malignancy, it's true, the overall capital is.
Next speaker is Dr. Sudhir Parak from the Department of Pathology.
So till now we spoke about the various cardiac tumors and the literature, but now we talk about the exact fact what we have in our department of the institute. So this is the data what we have taken from 35 years from 1990 to the total cardiac tumors of 438. If you see that, as literature says, 92% of the tumors are benign tumors and only 7 to 8% are malignant. If you see the distribution of benign tumors, myxomas obviously is the most common benign, about 402 cases. And if you see the site of origin of these, the left atria accounts for 77%, followed by right atria, and rest you may see myxomas in other sites also. We have encountered these in the ventricles, and most of them are single. Sometimes we have seen multiple myxomas involving all the 4 chambers that accounted for about 7 cases. So if you see the age group, again, this 5th and 6th decade is the most common adult age group for cardiac myxoma presentation, although it can occur in any age groups. If you see this, adult age group is the most common age group that is involved in cardiac myxoma, but however, pediatric age group also has 6%. Atrial location is the most common, amounting to 90%. Ventricular location is 2%, but other around 25 cases we did not have any site for definitive categorization. This is some examples how the cardiac myxoma looks on gross examination. It will have a stalk and a lobulated surface. This is what we receive in Department of Pathology. It is called myxoma because if you see the histopathology, the individual cells are quoted there. They are called as stellate cells or lipidic cells. They are floating in the background of bluish mucin. That's why it is called cardiac myxoma. we encounter two different morphological types. If you see the first picture, the surface is smooth, that means it's a smooth surface and lobulated. And another type of myxoma where the surface shows some villiform surface, finger-like position. These are the myxomas which commonly present with the embolic episode. So we have encountered few cases where the embolectomy showed myxoma. Later on, we diagnosed that there is a cardiac myxoma. This is not much of a diagnostic or prognostic or treatment aspect, but sometimes we do find some glandular element within the myxoma that shows that these myxomas are arising from pluripotent cells, so that it will have epithelial differentiation also. It is not much of an importance for the clinician, but for the pathologist, if the patient is also having adenocarcinoma of some other site, it can be misdiagnosed as metastasis. That's why the reporting pathologist should keep this in mind. So other tumors like cardiac fibroma, where it shows a lot of fibrosis and hyalinization, the entire tumor, variable cellularity, and the benign vascular tumors. That is also, you can see the variable size vascular channels. And this is infantile rhabdomyoma. You can see the arrow mark showing multiple rhabdomyoma, how it looks on microscopy, as Dr. Vinita mentioned, fluid look, that's why the cells look like clear cells. If you see the center cell, it looks like spider, delphi, rhabdomyoma cells, they are also called as spider cells. Along with malignant tumors, we had encountered some rare malignant tumors. One of the malignant tumors that we encountered was DSRTC. Desmoplastic is extremely rare tumor, and later on, patient with bad prognosis, later on, patient died because of multiple metastases. When it comes to non-myxomatous benign tumors, what data we have in our department? Next comes the cardiac myxoma, hemangioma, rhabdomyoma. But all the literature says that papillary fibrillostoma is one of the commonest, but we had only one case. I don't know why, whether it has been not sent to the pathology department for examination, or we are not finding these tumors in a AIIMS setup. We have no idea. When you see the malignant tumors, as previous speaker said, angiosarcoma is the most common, followed by synovial sarcoma, lymphomas, undifferentiated sarcoma, etc., etc. So all the different types of malignant tumors we have encountered, and these are some examples of angiosarcoma with a lymph node, bone marrow metastasis, one patient. So I don't know, there is a lot of concurrence between cardiac radiology and pathology. Whenever they say angiosarcoma, it has turned out to be an angiosarcoma. But this is one case of leiomyosarcoma. Just I just wanted to say, if you see the classification, WHO classification of cardiac tumor, we have seen almost all the cardiac tumors in our department at the Indian Institute. Only few entities which we missed, maybe missed because they are most common in autopsy. That we don't have much of autopsy. Thank you very much.
Thank you, sir. Next, I would like to call Dr. Shubham from the Department of Medical Oncology.
Thank you. Good afternoon again. So I shall be giving you a medical oncology perspective to the management of cardiac tumors. So we have seen this overview. So to first things first, cardiac metastasis is the most common, and it may happen from a whole lot of malignancies from the entire body. Most common ones are lung cancer, breast cancer, renal cell carcinoma, melanoma, amongst others. And the management of the underlying primary is as per standard oncology protocols for that particular malignancy. Nothing special about it. However, when we talk about primary cardiac tumors, 90% of them are actually benign, and the role of medical oncologist in this is actually limited. There are some case reports with the use of propranolol for the management of pediatric cardiac hemangiomas which do not regress, and it has been reported in literature. When we talk about the 10% fraction, which is primary malignant cardiac tumors, as we have seen, the most common of them are actually sarcomas, which constitute 65%. Followed by lymphomas, a quarter, and mesothelioma sometimes up to 8% of that. Now, cardiac sarcomas portend a very dismal prognosis, and the 5-year survival rate is as low as 14% in various series. And these are the histologies that can be seen. We have seen that cardiac angiosarcoma is actually the most common malignant primary cardiac tumor, and which is what we see in our clinics as well. And 80% of them actually present with metastases, which portends a poor prognosis. They follow a very aggressive course with a median survival of 6 to 12 months. Now, we have to establish, first of all, whether it is non-metastatic or metastatic. The management of non-metastatic cardiac angiosarcoma, as we have seen, involves radical surgery followed by adjuvant chemotherapy and radiotherapy. There is some upcoming literature about the use of neoadjuvant chemotherapy for downstaging these tumors so that they can be taken up for a safe resection. The management of metastatic or unresectable cardiac angiosarcoma, essentially it is palliative intent and portends a poor prognosis. Now, this patient presented to IRCH was a 69-year-old male with shortness of breath, had massive pericardial effusion with dilated pleural effusion. As we can see, there is a right atrial mass. Excision was done herein, and the histopathology turned out to be angiosarcoma. Followed by this, the patient was administered adjuvant chemotherapy with ifosfamide and doxorubicin-based chemotherapy. The patient had an excellent response, however, succumbed to the illness within 6 months of diagnosis. This was another patient who was a 61-year-old male presented to IRCH with dyspnea on exertion with atypical chest pain. As we can see, there is a very well-defined infiltrating lesion along the right ventricular free wall, which is also compromising the lumen of the right ventricle. However, this was a case of unresectable angiosarcoma, and this was managed with palliative chemotherapy, which is paclitaxel. The patient also succumbed within 6 months of diagnosis. Now, systemic therapy options for unresectable or metastatic cardiac angiosarcoma can be either anthracycline-containing chemotherapy or non-anthracycline-containing chemotherapy, which may range from single-agent doxorubicin, pegylated liposomal doxorubicin, even combination regimens like ifosfamide and doxorubicin, which offer the maximum response rate of up to 30 to 40% have been reported in literature. Paclitaxel also offers an exciting option for these patients, and even combination taxanes can also be used. So this was a patient who presented to IRCH, was a 48-year-old male, presented with pericardial tamponade, managed on the lines of pericardial tuberculosis at an outside center. Imaging detected a right atrial mass, and also cross-sectional imaging also revealed presence of frank pulmonary metastases, and biopsy was suggestive of angiosarcoma. So this was a case of metastatic angiosarcoma. And the patient was managed with weekly injections of paclitaxel dosed at 80 milligram per meter square. And post 4 cycles of paclitaxel, we can see that there is complete resolution of the pulmonary metastasis, and the right atrial mass also disappeared on imaging. The patient actually remained progression-free for 16 months. Now, talking about targeted therapy for cardiac angiosarcomas. Now, these angiosarcomas originate from the endothelium. So they are very vascular, and they thrive on neoangiogenesis. So the targeted therapy approach actually targets this angiogenesis, and the prototype of this is actually pazopanib, which we have seen in a couple of cases before as well. It is a multiple tyrosine kinase inhibitor, and it inhibits all of them and thereby inhibits downstream neoangiogenesis. This is often used as a first line for old or frail cardiac angiosarcoma, wherein they might not tolerate chemotherapy, and this might offer as a first line regimen. They are also used on progression after first line chemotherapy, and this is actually our go-to drug in the second line. Similar agents like sorafenib or regorafenib have also been used in literature with variable response rates, but they do offer significant palliation. So this patient was actually touched upon by my colleague who actually presented with a mass lesion in the RBOT with severe pulmonary stenosis and had progressed actually post ifosfamide adriamycin chemotherapy. She was started on pazopanib as second line, and she continues to be progression-free till date for the last 18 months. Other malignant cardiac tumors include rhabdomyosarcoma, which are treated with the standard VAC chemotherapy. However, have a survival of less than a year in literature, the reported literature. Then we may also have primary cardiac lymphomas, which are most commonly non-Hodgkin lymphoma of the diffuse large B-cell variety. They are usually seen in immunocompromised individuals, post-transplant recipients, HIV, AIDS population. They are managed with the standard R-CHOP backbone, and they have exciting response rates of up to 70% with median survival crossing 3 years landmark. So this is perhaps one of the cardiac lymphomas wherein the prognosis is not that grim, and they do not even require a surgery as well. one rare malignant cardiac tumor is also mesothelioma, which also follows an aggressive course and is probably associated with asbestos exposure. Usually, palliative chemotherapy is administered, and the median survival is close to 6 months in these populations. Thank you.
Next to enlighten us is Dr. Surendra Saini from the Department of Radiation Oncology.
Very good afternoon. The radiotherapy can be used in the advanced setting, especially in the malignant tumors, after discussion of the primary disease, and in definitive setting for a tumor that is not technically resectable, and sometimes it is used preoperatively where the disease is not resectable, but after radiation therapy it can be resectable. And most commonly, radiation therapy is used for the metastatic lesions for the palliation. The radiation therapy technique we commonly use are 3D CRT, IMRT, VMAT, SCRT. Cyanide is a special kind of linear accelerator that delivers 6 MeV photon on a robotic arm. Proton therapy and carbon ion therapies are new modalities that deliver higher doses to the target and spare the normal structure. In the cardiac radiotherapy, there is a challenge of motion because the cardiac masses are subject to the dual motion, respiratory as well as the intrinsic cardiac contraction. Intraflexion motion variability makes reproducibility difficult, especially during the long treatment session. So, during the treatment, the coronary arteries and wall may receive higher doses. Those are very sensitive for the radiation, and the outcome may be affected sometimes. So, standard immobilization devices provide little benefit during the treatment of cardiac masses, so necessitating advanced imaging and getting strategy, especially getting for the cardiac tumor radiation therapy. We usually take a generous PTV margin for the malignant tumor, but in the cases of cardiac masses, we have to be very cautious in deciding the PTV margin to spare the normal structures. So, for the irradiation of the cardiac masses, the motion management strategies, those are most commonly used are respiratory gating and cardiac gating, ECG triggered RT. These dose constraints for the cardiac structures should be followed stringently because the cardiac structures may be very sensitive for the radiation, especially the coronary vessels and the valves. Now come to the case. This is the case of renal cell carcinoma, a 50-year-old male who was diagnosed 9 years ago with the renal cell carcinoma. Initially developed metastasis in pancreas, then lung, treated by the chemotherapy and immunotherapy, and the pancreatic mass was treated by radiation therapy also, SCRT. Later, before few months ago, he developed this intraventricular septal metastasis. Because renal cell carcinoma is less sensitive with the radiation therapy, so we opted for the hypofractionation regime, 30 gray 5 fraction. And we can see in the coronal, cervical, and the axial view that the 50% isodose line, that is around 15 gray, or 15 gray, that is around 1 centimeter or 1.5 centimeter to the lesion, and other cardiac structure are spared from the high doses. After 3 months of the MRI scan shows in axial and the cervical view that the mass was stable. This is a report from 5 cases where the cardiac metastases were managed with the MRI guided radiation therapy. So the left one is the case of metastasis from the lung, and the right one is metastasis from the breast cancer. So the disease, the dose of the radiation therapy was decided based on the primary disease. In the first case, it is 60 gray to the GTV and 50 gray to the PTV to spare the normal structures. But in left side, it is a breast case, breast metastasis. So considering the alpha beta ratio, the hypofractionation regime of 40 gray in 5 fraction was obtained. The proton therapy is also tried in the cardiac masses. Mughalaya shows the feasibility of proton beam therapy, where the higher doses, around 60 gray, can be delivered to the cardiac mass and sparing the normal structure. The newer modality, carbon ion therapy, is quite
may be quite helpful in radio-resistant tumors where the dose, a higher dose may be required. In the galvanizing therapy, in this 16 patient series by MLA et al. So that the dose can be increased up to the 7 grade and the mean cardiac dose is less than 3 grades. So the complication of radiation can be used. So adjuvant radiation therapy is associated with the longer overall survival when used with the surgery and chemotherapy. Advanced radiotherapy technique like SBRT, proton therapy, or carbon ion feasible in the radio-resistant cases with acceptable adverse event. Adverse event with the radiation therapy when delivered meticulously are less than 10% and are recurrent atrial fibrillation, segmental hypokinesia, and constructive pericarditis. So RT will be considered as a part of multimodality therapy with careful risk-benefit discussion, especially when surgery or systemic therapy are not viable options. Thank you.
So, before I take up any questions on this topic, I request Dr. Roma, head of cardiac pathology, and Dr. P.I. Lalika, head of cardiac radiology, both of whom have got great experience in this topic, to give some comments.
Good evening, everyone. Actually, Professor Sudhir has nicely, eloquently described everything, with possible last 35 years of experience. We had a small publication by two of my pool officers, Professor Narendra, who is in now in PGI, and Dr. Sudhi Sharma, with Balram Irons Lab. And this pediatric, we had 16 pediatric cases, of which 13 were myxoma, one was undifferentiated pleomorphic sarcoma, one was fibroma, and another one was the rhabdomyoma. And this was between 1995 to 2010, prior to Professor Sudhi's journey. And another one, very interesting case we saw, but we could not publish that case, was inflammatory myofibrillous tumor affecting the tricuspid valve way back in 1994. Because ALK1 is a specific thing for this tumor. We didn't have that stain during that time. IHC was not available, so we could not confirm the diagnosis. Thank you so much for your patience here. Now I will request Professor Jalia.
It was wonderful to hear, all everyone talking about cardiac mass different aspects. Regarding imaging, Vinita has already told you, cardiac MR is the way we approach a cardiac mass whenever there is one. So most importantly, I would say whenever, see the thrombus thing first, the thrombus is something which we see most often. So to differentiate thrombus from any structure, we know myxoma can occur in all the four chambers. So for between myxoma and thrombus, first thing, cardiac MR, is something which is very, very useful. Then there are some masses which we are very confident when we say, so he has, thank you, he has validated cardiac MR against histopathology, it is considered a gold standard. So there are certain masses which when you suspect, cardiac MR we are very, very sure when we say, yes, we are seeing fibroma, when we are seeing, say, angiosarcoma, a myxoma, a thrombus. So there are some tumors which we are very sure. When we are not, we do mention whether it is benign, malignant, and we try to give some differential diagnosis. But I just would like to just reiterate that cardiac MR is almost diagnostic in some masses. So keep that in mind when sending requisitions. CT is just an example we are using in certain cases only, like Vinita. Thank you.
Just would like to make some comments. The Rama is there, the saying, Sorry, you want to say something?
I think in pediatric cardiac tumors, deep diving and something is already highlighted. The introduction of AIIMS has really made difference in treatment. In fact, large tumors which used to give us a lot of discomfort to us and the patient is now gone. We treat them well and they're outcomes.
Any questions or comments from? So I think we have had a very good session. We have exceeded our time, but thank you all the speakers. We have compiled, and I think this has been a very good compilation of cardiac masses and cardiac tumors. Many of these patients, they are referred because the local facilities they don't have expertise, and these patients are very difficult to treat. Sometimes prognosis is not very good, but prognosis gets greatly improved if the organized management is there, investigation treatment is there. So thank you all for this session. Thank you.